busy schedule. Actually, I think a lot of insulin conferences, summits are going on all the time. And he is the most sought after luminary from our country to speak on any subject for that matter. And if he has devoted a little bit of his time to this presentation, then my day is made. Thank you, sir, for your presence. And without wasting much time, I'll go through the presentation. These were the presentations which we went through. I think first four and next four. And then today's topic is about the complications. Of course, when insulin got discovered, Frederick Allen, the famous diabetes physician from New York, made a statement that we have conquered diabetes finally. But he was wrong. But Dr. Jocelyn was more forthright in his opinion that we have a long way to go. It is not the end of diabetes. The first complication which the physicians in those times encountered was hypoglycemia. Obviously, insulin was new to them. So the potency of every batch also varied. So the risk for developing hypoglycemia was very high. And that was the first acute complication noticed by the doctors. Of course, before the discovery of insulin, most people presented with diabetic ketoacidosis, which was another acute complication, but that became, the incidence became slowly reduced with the arrival of insulin. So hypoglycemia became the commonest problem after the discovery of insulin. This statement by Dr. Jocelyn sums it up all. I quote him that adherence to treatment with diet, insulin, and exercise finds ample justification in the good health, comfort, and longevity of those who obey the rules, as contrasted with the poor health, suffering, and shortened lives of those who are careless. So he is talking about the compliance and the motivation of the patients to contribute their healthcare. So diabetes being a chronic disorder, it's not about the physician or the treatment, which is all going to matter. What is more important is the patient, who is a fulcrum of the whole show. The patient has to contribute to keep the health intact. So Jocelyn was far ahead of his times in every one of his statements. And what happened after insulin got discovered? The natural history of the disease got altered. So you can see on top the natural history of diabetes, especially type 1 diabetes, before the discovery of insulin. Once the patient developed type 1 diabetes, it progressed fast, and within months, the patient died unless the severe dietary restrictions of Allen's diet was instituted. Otherwise, death was a certain outcome for those people with the type 1 diabetes. Then, once insulin got introduced, the course of this disease got transmuted. You can see they introduced diet therapies, then insulin came, then prolonged the life, then infections were tackled with antibiotic, and blood pressure was controlled with antihypertensives, and we have other technologies. So successive eras of new interventions altered the genesis of this disease, which got transmuted. And this is a paper, a nice paper, which got published by the Jocelyn group, by Elliot P. Jocelyn himself as a first author in the British Medical Journal way back in December 1950. You can see before discovery of insulin, they had patient data, Jocelyn Clinic. So starting from 1898, remember, insulin got discovered and came into use in 1921-22. So they had patient data even before that. So 1898 to 1950, before discovery to after discovery, around 52 years of patient data they published, how the patients fared. If you look at the graph here, as the decades unfolded after the discovery of insulin, the incidence of coma and infections, even tuberculosis in type 1 diabetic people came down. So slowly the acute complications and infections rate came down with better control of diabetes as well as introduction of antibiotics and anti-tuberculous therapy. But if you look at the chronic complications like cardiac or kidney failure, those complications remain unabated. So they continue to ravage the group of type 1 diabetic people. And if you look at the long-term sequelae of juvenile diabetes, by duration of diabetes, you can see in this graph, as a person with diabetes lives longer and longer, as the age progresses, they have more number of years of diabetes. So the complication rate also parallelly goes up. You can clearly see the blood pressure, the incidence of blood pressure, and the arrival of proteinuria and retinal involvement all went up with the duration of diabetes. So even with good treatment, with longer duration of diabetes, people developed complications. And if you look at the age of the patient, the sequelae versus age of the patient, as one progresses in age, suppose assuming that somebody developed diabetes, say less than 10 years of age, type 1 diabetes, and as they became older and older, the risk for getting complications went up parallelly. So this paper showed the arrival of complications because people started living longer with insulin, but then they have to face the consequences of living longer. That is in terms of complications and affected decreased quality of life. Again, this is a nice paper published from the same Jocelyn group. This is after Elliot P. Jocelyn. Howard Root was the first author. This paper was the first one which mentions about triopathy. That means the group of microvascular complications, namely neuropathy, retinopathy, and nephropathy, they called it together as triopathy. And they documented this in 155 patients in this paper. And this was one of the recent Nature publications published in this June 2021. This is a very nice publication, which is mentioning about the most important milestones that happened starting from discovery of insulin till the modern technologies of today. And I have to mention here that Nature invited many doyens of diabetes, legends, and only one of the Indian who was invited to advise this publication was Professor V. Mohan, who is attending this presentation today as a chief guest. So this was a big honor for our country when 100 years of insulin is getting celebrated. Leading luminary from our country was invited to give advice about this publication. And in this publication, milestone number 5 was about diabetes complication. This mentions, the heading is a pioneering study of diabetes complications. And this study was conducted by Jean Pirat. He was a clinical diabetologist in Brussels, Belgium. He is recognized for his personal study of 4,400 diabetic patients whom he followed between 1947 to 1973. More than 25 years, he had a pool of diabetic patients and he followed them meticulously and published. At the time, diabetes control could only be assessed by urine analysis and occasional blood sugar determinations. So Pirat was the first one to convincingly demonstrate that good metabolic control reduced the incidence and severity of all the microvascular complications. His observations were later confirmed by the DCCT study, which was a landmark study conducted 20 years later. Unfortunately, the DCCT investigators never acknowledged Pirat's work in their reference. So Jean Pirat did pioneering work about how controlling diabetes can prevent future complications. And just to show you about the magnitude of his work and the enormity of his work, there is a comparison between UGDP study, which was conducted by university groups, versus Pirat's group. So you compare the UGDP study, the period of observation was about 12 to 13 years. Whereas Pirat followed up his patients for more than 25 years. And the university group had only 716 patients enrolled, whereas Pirat had 2,795 initially, then it swelled up to 4,500. And if you look at the number of clinics participated, 12 clinics participated in the university group study, whereas only 2 clinics, only 2 doctors were in charge of this Pirat study. So no mean achievement. And Pirat practiced in this clinic, César de Pape Clinic in Brussels, from where he published these 2 landmark papers, paper 1 and paper 2. So this study was a forerunner to Diabetes Control and Complications Trial, DCCT. And if you look at the data pool, you can see the cohort of patients as they got enrolled. Later on, as years went on, slowly the numbers whom the Pirat could follow up came down. So there was an erosion of subject population. Actually, Pirat also mentions this in his paper. Faced by this type permanently by migration, 2,795 cases. We succeeded in keeping 97 cases at the 15th year, 29 cases at the 20th year, 5 cases at the 25th year, in spite of fairly strict discipline of treatment. And the way he divided his patients into 3 categories is mentioned in this table. So he just divided them into 3 groups: good control group, fair control, and poor control group. Good control group had a postprandial of less than 200, fasting was less than 120. And fair control, they had a postprandial of between 200 to 300, and fasting was between 120 to 200. And anything postprandial above 300 or fasting more than 200 was considered as poor control. And when he published the data, you can see the prevalence of neuropathy rose from 7.5% at the time of diagnosis of diabetes to approximately 50% after 25 years. On top, you can see the hanging bars are the number of patients who are participating in the study. As years went on, you can see the numbers dwindled because they were lost to follow-up, whereas the risk for developing neuropathy increases as the years went on. So you can see on the lower graph, you can see the increased incidence of neuropathy. Almost 50% of the patients develop neuropathy after 25 years of diabetes. For want of time, I'm not going to discuss every detail of this slide. So you can see clearly that there was also an increased prevalence of nephropathy and retinopathy as a function of duration of diabetes. As the duration of diabetes increased, the complication rate also increased. And then what about control? If people maintain their control, will there be any solace for them? Yes. So in this graph, you can see different grades of retinopathy as a function of good versus poor glycemic control. So people who had good control, they had lesser chance of developing retinopathy, whereas people who had very poor glycemic control definitely had an increased incidence of retinopathy. And Pirat, in this paper in 1978, amazingly concluded at the discovery of diabetes, he is mentioning that at the time of diagnosis of diabetes, we observed prevalences of 7.5% for neuropathy, 7.2% for retinopathy, and 1% for nephropathy. So even at the point of diagnosis, people had a small risk of having some complications because it get diagnosed a little late. And it conclusively proves that diabetic triopathy and not atherosclerosis is a function of the duration and intensity of the diabetes. So he's talking about the glycemic control influencing the microvascular complications more than the atherosclerosis. Of course, this can be lessened by treatment. This fact should encourage physicians to strive towards normoglycemia and diabetes therapy, while at the same time recommending various methods of hygiene, which could slow down the development of atheromatosis and hypertension. So he's again advising physicians to address other risk factors for atherosclerosis than concentrating only on glycemic control. And we will move on to retinopathy. Actually, this is the biggest chunk of this presentation. Somehow ophthalmologists, they have a knack of keeping their record intact, and all historical details are available freely as far as ophthalmology is concerned. Whereas neuropathy and retinopathy, the papers available are rather meager. In 1846, the French ophthalmologist Apollinaire Bouchard, he reported the development of visual loss in the absence of cataract. So he was the first one to notice that without even cataract, diabetic patients started losing their vision if they have little longer duration of diabetes. This loss of vision was partly reversible, and in most cases, amelioration was associated with better control of diabetes. He also noticed that those who controlled their diabetes better, they had improved vision. That was an important observation. And then Edward von Jager, who was the first one to describe retinal changes in a diabetic patient. This was way back in 1855. So on the right, you can see the fundus drawing done by Jager. The first fundus drawing of diabetic macular changes was published by him in the middle of 19th century in 1855. Amazing. With whatever equipments he has got, he observed the retina and drawn the retinal changes also. In fact, he published 2 atlases. But then there are other people who are not so hopeful about diabetes and retinal changes. Another famous man, Albrecht von Graf. We all must be knowing about von Graf. Von Graf openly claimed that there was no evidence of causal relationship between diabetes and retinal lesions. He was a doyen at his times, and when such a person makes a statement like this, that becomes a discouragement for the researchers who are trying to do something in this area. So he was the one who introduced iridectomy for glaucoma, and von Graf knife for cataract surgery was quite famous during his times. Then in 1875, Frenchman Apollinaire Bouchard, again from Paris, he published a book, De la glucosurie au diabetes sucre, in which he described fluid and lipid accumulation in the macula. So he was the first one who noticed the macular changes that happened, or macular edema which happened due to diabetic retinopathy. And in 1868, Henry Drury Noyes first photographed the retina of a rabbit. So he produced a photograph of the retina of a rabbit. This was a big advancement. And this was the book. On the right, you can see his book, a treatise on the disease of the eye. Then came Hermann von Helmholtz. Actually, Helmholtz is a very popular physician of his times. He commented that he could not believe that photographing the fundus oculi would ever succeed in humans. See, after looking at the photograph by Henry Noyes, Helmholtz commented that it might not be possible to do the same in a human retina. It's not possible to take a photograph of a human retina. Helmholtz, on the right and left of his picture, you can see so many contributions. Actually, he was an astronomer, he was a mathematician, he published in physics and chemistry, he was into music and physiology and whatnot. So, so many eponyms with his name: Helmholtz equation, Helmholtz coil, and so on. So when again such a person discourages people that it might not be possible in humans, again, that was a problem around that time. Then Wilhelm Manz from Germany, he published the first photograph of the proliferative diabetic retinopathy. In 1876, he discovered the features of proliferative diabetic retinopathy. On his seminal paper, he called this condition as retinitis proliferans, almost similar sounding name. He described fibrovascular degeneration of the optic disc, vitreoretinal adhesions on top of the picture you can see, tractional retinal detachment, and vitreous hemorrhages. All were described in 1876 by Wilhelm Manz. Then the first classification of diabetic retinopathy was attempted in 1890 by Julius Hirschberg. He distinguished diabetic retinopathy into 4 types: retinitis centralis punctata, the hemorrhagic form, the retinal infarction, and hemorrhagic glaucoma. More than his categorization of diabetic retinopathy, which was not followed later on, he was known for this work, which is enormous by any standards. Actually, he published 9 volumes of history of ophthalmology. Actually, you can see those big volumes there. He wrote all these volumes between 1899 to 1917. It took almost 18 years for him to complete the history of ophthalmology. A single specialty having so much of history. Amazing. And so naturally, the Julius Hirschberg Society was formed, which was an international association for the history of ophthalmology and its promotion. And then came Arthur James Ballantyne. Arthur James Ballantyne was an ophthalmologist from the University of Glasgow. He provided the first evidence which suggested that diabetic retinopathy represents a unique vasculopathy, because before his times there was a confusion whether diabetic retinopathy changes could have been influenced by the hypertension also. So there were a lot of confusion, whether it's due to hypertension or diabetes per se. So he was the first one who provided evidence for this. So a full histopathological description was published in 1944 by Ballantyne and Lowenstein. They first coined the term diabetic retinopathy. You can see on the right their first paper, Diseases of the Retina, the Pathology of Diabetic Retinopathy. And then Gerd Meyer Schweckerath, he was the first one to treat retinal diseases with light coagulation. Schweckerath, he has got a nice story behind. Actually, a solar eclipse happened on 9th July 1944, which had damaged retinas of those who viewed it. So a lot of people with diminished vision came to his clinic complaining that they witnessed the solar eclipse and then they have lost the part of the vision. And when Schweckerath examined their eyes, he could find burns in the retina, many burns in the retina. And he had a very sleepless night on that day. He wondered whether it would be possible to treat eye disease by using photocoagulation to create similar burns in the retina. So the idea of producing a scar by means of light came to him following a sleepless night in which, for fear of forgetting, like our Banting, if you remember, in the middle of the night, he woke up and wrote a few sentences about his idea about insulin. So similarly, Schweckerath also recorded 2 words in a paper, light and coagulation, should he forget the next day, on a note. In 1949, he performed the first successful treatment of a retinal detachment with a light beam. What he did, he self-constructed a device on the roof of the ophthalmology clinic at the University of Hamburg-Eppendorf. So on the top of their building, he erected a device which focused sunlight through a telescope and utilized a series of mirrors leading into the operating room. He led the light into the operating room and into the eye of patients. So a lot of work there. And unfortunately, in Germany, it's a country with a lot of clouds. It's not very sunny like our country. So he had to wait hours together, making the patient lie down and waiting for the sun to appear and then get the light to burn their retina. But he did that. And then he found the method of using sunlight very cumbersome. Then he discussed with ZS, the company, lens making company. Then together they made this xenon coagulator, with which he introduced the use of xenon coagulator to treat retinal diseases, which laid the basis for the current use of laser therapy for diabetic retinopathy. Now, ophthalmologists are not using a light source. Instead, they are using lasers to burn the retina. His method of photo or light coagulation has now been replaced by the application of laser, but nothing has changed in the principle of the treatment of pre-stages of retinal detachment or of tumors and vascular diseases and of diabetic eye changes. Still, the principle remains the same. On August 22nd, 1949, Mayer Schwickerath carried out the first light coagulation with xenon light source on a patient with imminent retinal detachment and saved his eyesight. Then came Robert Mashimer. He is considered the father of vitreoretinal surgery, who later retired as the head of Duke University Ophthalmology Clinic. So he was a Jew who was practicing in Germany when Nazis started killing the Jews. So again, he had a very pathetic story. His wife was also a doctor. They had two small children, and they had good practice. What happened? Slowly, the Jews they were not allowed to practice, and he was thrown out of his university. He became jobless, and he was not allowed to practice also. And at some point, they decided to leave Germany. But unfortunately, his father-in-law and mother-in-law were in another city. They couldn't reach them when they escaped Germany. So the father-in-law, who was another ophthalmologist, a famous ophthalmologist, got caught inside Germany, while the young couple with their kids escaped to United States of America. Before escaping, the head of the department of his ophthalmology unit gave a letter of recommendation, which was full of praise for Dr. Robert Mashimer's ability. And this HOD actually was a German, so he was not a Jew, but then still he gave a word of praise for Robert Mashimer. With that, he could get employment in 4 or 5 universities as soon as he reached United States of America. He settled in Miami, where he started an ophthalmology unit. And when he started his work on important important subjects, his father-in-law in Germany hanged himself, and mother-in-law was caught alone. So he was under mental turmoil when he started his work in US. With this background, you have to understand what he did. So otherwise, it's very difficult to appreciate what he did. So Mashimer, actually, he was a father of vitrectomy. He noticed that during a cataract surgery, one of his colleagues he removed a bit of vitreous on the back of the lens. Before those times, nobody touched the vitreous. When they did the cataract surgery, they just removed the lens, came out. This small removal of vitreous caught the attention of Dr. Mashimer. He thought, why can't we remove the vitreous if it was full of bleeding or some other problem and do something with it? So he was just thinking of treating vitreal disorders through some means, but he didn't have any equipment to do that. So what he did, he found space in his garage where he took eggs and started experimenting with the eggs. Like he started removing egg white. You just imagine egg white is a vitreous within the eyeball. So meticulously, he started removing only the egg white, leaving the yolk behind like that. So he began to fabricate and test in his garage using an airplane drill in a syringe with a suction tube attached and a raw egg. The raw egg helped as a surrogate for the eye and vitreous. But then he is not an engineer. So naturally, he required some help. So he employed a biomedical engineer. We'll come to that later. So encouraged by the results of his nascent device, which he devised in his garage, he collaborated with Parel, a biomedical engineer, to create a more sophisticated instrument. You can see how the improvement happened with his suction apparatus. And Jean-Marie Parel was a biomedical engineer who joined his department, and he developed a remarkable new surgical instrument from the Mashimer's garage prototype. This was the first vitreous infusion suction cutter, VISC. And this is Dr. Parel in his ophthalmic biophysics center in Duke University. And in those times, the surgeons operated, whenever they operated the vitreous retinal detachment surgery and all, they made the patient upside down. The position of the patient was to be upside down. So Parallel devised a rotating surgery table. You can see the table can be rotated either way. So this was made by Parel. And this rotating table was used for retinal detachment surgery. So gas was injected into the eye and the patient remained face down during the entire course of surgery. And you can see here the vitreous infusion suction cutter devised by Parel and Meshimer. So Dr. Meshimer performed a vitrectomy with this instrument using the open sky technique, and it worked very well. He did once a cataract surgeon removed the lens in front of a diabetic patient with cataract and long-standing vitreous hemorrhage. So once the lens got removed, Meshimer did this procedure to remove the vitreous. And then they improved the vitreous infusion suction cutter, which got illuminated. It is called endo-illuminated vitreous infusion suction cutter. Then they devised a membrane peeling cutter also. Here you can see Dr. Meshimer doing a vitrectomy. By employing a host of instruments and techniques which allowed surgery inside the closed eye, vitrectomy was made possible, where they removed the diseased vitreous and intraocular scar tissue, and they could even elegantly reattach the retina. So Dr. Meshimer is best known for his development of pars plana vitrectomy, a surgical procedure which has revolutionized the treatment of posterior segment eye diseases. The first pars plana vitrectomy was done on 20th April 1970, which marked the launch of a modern era of vitreorectal surgery. And this is Dr. Ailo on the right side and his father-in-law, Dr. William Beetham, both ophthalmologists working in the Jocelyn Clinic. They pioneered the use of laser photocoagulation for the treatment of diabetic retinopathy. This bold approach was based on their clinical observation that proliferative diabetic retinopathy was often less active in patients with retinal scarring. So they intentionally scarred the retina with the lasers. And Dr. Ailo, he served as a leader in two of the most successful randomized controlled trials, the diabetic retinopathy study, DRS, and the early treatment diabetic retinopathy study, ET-DRS. In these, one eye of the patient served as the treated eye and the other eye as a control. So same patient, one eye was a control eye, the other eye was under treatment. Both studies proved the effectiveness of standardized application of laser photocoagulation therapy in the progression of prevention of retinopathy. Here you can see the ET-DRS retinopathy severity scale. It is quite complex. I am not an ophthalmologist, but it is very easy to see how complex it is. And Dr. Ailo is also known for another first. Actually, he was the one who first introduced the world's first telemedicine system. So Dr. Ailo realized that a major limitation was the late diagnosis of diabetic eye diseases in most of the patients because they didn't have any access to specialist care. So in 1990, he began working with Sven Erik Borsell to develop a telemedicine system using advanced video technology for the remote early detection of abnormal blood vessel growth in the retina as well as other retinal changes. So in any remote area, the patient's retinal picture can be photographed and sent to the expert who is working in the tertiary level hospital, which we use in other systems also. Now, diabetes, any disease you can treat with telemedicine. And this is when Erik Borsell of Harvard Medical School, who along with Ailo developed this telemedicine system for the first time in the world. Then we will finally move on to the diabetic nephropathy. It was Captain Dr. John Rollo, who was working in the British Army, who first noticed that the diabetic urine, in some patients, diabetic urine contained a coagulable material. This was noticed in 1798. Actually, in fact, he identified the protein in urine, proteinuria. So he mentioned that there is a coagulable material in diabetic urine. Then came Paul Kimmelstiel. Actually, Paul Kimmelstiel also is from Germany, who also escaped to United States of America when Hitler started killing the Jews. And Paul Kimmelstiel, actually, when he tried to transfer most of his savings to United States before he left US, 96% of his savings were not transferred to his account. Only 4% was transferred by the German government. So with very meager amount, he landed in US. And then he, along with, this is Clifford Wilson. We have seen Kimmelstein first. This is Clifford Wilson. He is from London Hospital. He is a professor of medicine. Clifford Wilson, along with the German-American pathologist Paul Kimmelstiel, published a landmark paper in 1936 on the glomerular appearances of patients, what we call now as type 2 diabetes. And this resulted in a lesion of diabetic glomerulosclerosis. Now it is known as Kimmelstiel-Wilson lesion. In 1941, along with Kimmelstiel and Frank Byram, Clifford Wilson published his classic work on the vicious circle of renal damage and high blood pressure in what was then called malignant hypertension. Yes. Paper on this, which appeared in 1941, was an immediate classic. So Wilson was the one who collaborated with Kimmelstiel. He published a lot about the diabetic changes which happened in the kidneys. And this is the first 1936 paper of Kimmelstiel and Wilson, where they describe the capillary changes of the renal corpuscle in the course of diabetic renal disease, thereby unraveling the connection between diabetes and nephropathy. And many decades later, Kimmelstiel, almost 4 decades later, the Hamburg University made a late and conciliatory publication. In 2014, Paul Kimmelstiel was honored and his fate commemorated with the placing of this small cobblestone-sized memorial in a prominent location at the entrance of a new clinic of University Hospital Hamburg-Eppendorf. So, almost 40 years after his departure, they acknowledged his work. And this paper appeared in 1968, which mentioned about basement membrane thickening of quadriceps muscle capillaries in pre-diabetic patients. So this paper was published by Sipperstein and colleagues. He proposed that microangiopathy was not due to metabolic derangements of diabetes, but due to genetic predisposition. Of course, he was wrong. And later, this paper was disputed. But what is important in this paper was he noticed basement membrane changes, clear thickening. There you can see the clear thickening of basement membrane. But his conclusion was wrong. And then there was evidence that abnormal state of diabetes is necessary for the development of lesions in the glomeruli. This paper talks about the development of lesions in the glomerular basement membrane and mesangium after transplantation of normal kidneys to diabetic patients. So when you transplant a normal kidney into diabetic patient, obviously, if the diabetic patient is not controlling the glucose level, the transplanted kidney also started showing changes. So they proved that the higher level of glucose is necessary for the changes to occur in the diabetic kidney. And then in early CKD, there is an increased kidney as well as increased organs and increased kidney size and glomerular filtration rate in early juvenile diabetes. And the next important paper is about diabetic glomerulopathy, where they describe the structural characteristics of the early and advanced stages of diabetic glomerulopathy. And this is another important paper, only a single case observed by Berkman and Harold Rifkin, where a patient had renal artery occlusion of one kidney. So one kidney was ischemic and the other kidney had normal blood flow. You can see on the left, the ischemic changes which happened in the kidney with renal artery occlusion. Whereas on the right, you can see the normal kidney, where is normal blood flow. So the same level of glucose was flowing into this kidney. So naturally, it showed diabetic changes. So they proved that the glucose level abnormality, the metabolic abnormality is necessary to produce these kind of changes in the diabetic kidney. And this was the first paper which talked about glycosylation of. So glucose. And again, this is another important paper which talked about the change in the electrical charge in the membrane of a diabetic kidney. So it mentions electrical charge, its role in the pathogenesis and prevention of experimental membranous nephropathy in a rabbit. Then they extrapolated to this to the diabetic kidney also. Mogensen is an important researcher who published a lot about diabetes, kidney, and cardiovascular disease. They have an intimate relationship, both kidney and cardiovascular disease. I think at the end of this presentation, we can listen to Professor Mohan about all this. And Frederick William Pavey in 1885, he described diabetic polyneuropathy. So this is the last microvascular complication, neuropathy. And Paul Brand, we are coming to India now. Paul W. Brand, who lived between 1914 to 2003, he worked in the leprosy center, CMC Vellore, and then moved on to leprosy center, Corville, Los Angeles. He was a hand surgeon who changed forever how leprosy patients were treated by medical professionals and perceived by the rest of the world. You may be wondering why I'm talking about Paul Brand, who was a leprosy surgeon. So actually, whatever he found in leprosy can be extrapolated to the diabetic neuropathy. So we'll come to that now. Actually, this talent of Dr. Brand was identified by Dr. Robert Greenhill Cochrane, who was a dermatologist at CMC Vellore in those times. So Dr. Cochrane invited the young surgeon who just returned from UK after finishing his FRCS to come and see the leprosy patients, because he was struggling with leprosy patients as a dermatologist in CMC. So what Paul Brand studied a lot of leprosy patients, and he recognized that tissue healing was not affected in leprosy, and that the shortening of fingers and toes resulted from repetitive unrecognized microtrauma in the presence of loss of protective pain and temperature sensation in the hands and feet. So this knowledge eventually was to be applied to the management of diabetic retinopathy. Remember, the diabetic patient with a neuropathy also has the same changes. Like the person has got loss of protective pain and temperature sensation, like a leprosy patient. So Paul Brand thought the pain was a gift from God. He said, God designed the human body so that it is able to survive because of pain. He gives pain such an importance in our well-being, because without pain, we won't realize that something is going amiss. So he said pain is God's greatest gift to man. And he was the first one who used armadillo foot pad culture to culture lepra bacilli, because lepra bacilli takes months together to grow in a culture. So he fast-tracked the culture of lepra bacilli by using the live armadillo foot pad of mouse. And here you can see Paul Brand examining a leprosy patient. Once to a leprosy patient, he said, with the surgery, I can make your fingers move and you can start doing work. The patient started crying, it seems. Then he wondered whether I, with my broken Tamil, have I told something wrong? He asked his assistant. The assistant told him that he is crying because you touched his hand, because nobody has ever dared to touch a leprosy patient's hand before. So that was the nature of Dr. Brand. Again, you can see him meticulously examining a leprosy patient here. And he was the one who first introduced serial casting for flexion contractures. And he introduced a tendon transfer procedure in upper limbs. It is called brand operation, which provided enough movement for those patients to do some kind of work. And here you can see an agricultural laborer wearing a glove and custom-made footwear to protect the feet and hands. The person with the leprosy is agricultural laborer. He's ready for work because of brand's innovations. Once in a big conference, an audience, a doctor from an audience, from the audience asked Dr. Brand, what is the most important thing that we as physicians can do to reduce amputations in diabetes? A very important question to Dr. Brand. Brand answered, every time you see a patient with diabetes, always remove the patient's shoes and socks and inspect the feet. If all of us followed this simple rule, this would have a big impact on reducing amputations in diabetes. So he said, see the foot, touch the foot, examine the foot, and help the patient. We are coming to the end of this presentation, and these are his statements. Much of what I had described in leprosy in 1940s is transferable to patients with diabetes. In America, ulcers in diabetics were still called diabetic ulcers in 1960s rather than neuropathic ulcers. Nobody is realizing that it is neuropathy which is causing ulcer, not diabetes per se. And any patient with plantar ulcer who walks into the clinic without a limp must have a neuropathy. If they don't have pain, definitely there is neuropathy. He pioneered the use of infrared thermography to identify areas of skin prior to breakdown in an insensate limb. So he could even identify the areas at risk by using infrared thermography. Then he said, because where I practiced medicine, both in CMC Vellore and as well as in Carville, where he headed the leprosy center, he did not make much money, because where I practiced medicine, I never made much money. But as I look back over a lifetime of surgery, the host of friends who once were my patients bring more joy than wealth could ever bring. So with this, I conclude this presentation, which is all about the history of complications, especially microvascular. Thank you for your patient listening.
Very much, sir. Wonderful presentation. Dr. Mohan, sir. Professor
Hey,
Mohan.
I'm here.
Yes, Mohan.
Very much here and very much enjoyed the presentation as usual. The depth, be able to hear?
Congratulations to you, sir.
Yes, sir.
Oh, thank you. That nature, yeah. I was also surprised when they wrote to me. Congratulations, Dr. Mella Perumal. Somehow, because Madam sent something 9th and last, I also thought 12 were there. Why she wrote 9th and last? I was wondering. I thought you were prematurely winding it up. That's my mistake when I said that it's a last. Let's continue until you are finished. Wonderful. I think the depths into which you have gone. Of course, I used to hear about Paul Brand very often from Professor Andrew Bolton,
Yes,
who was trained by him. His interest in neuropathy came. He's now the president of the International Diabetes Federation, as you know. And he was trained by Paul Brand. And so he always quotes Paul Brand. And pain is the greatest gift to mankind by God. That is a famous statement from Paul Brand. It's echoing a little. So just a few random thoughts. First of all, I wanted to share with you one good news that some of you would have read in the newspapers today, that stem cell therapy has cured the first type 1 diabetic patient. Unlike many other things where we read which are just myths and fake news and so on, this one is true, because I've been following Doug Melton's work at Harvard now for over 20 years. He started with small incremental work on stem cells. In fact, we also produced islet cells, beta cells in our lab. But the problem is you need very heavy funding. And we applied for several funding. We never got it, and the scientist left me. She went away to Pfizer because we didn't have continued funding. But we actually produced islet cells in our lab. which was able to produce insulin. It was responding to glucose, and we were able to produce clusters. And then in the lab, we were able to actually show that it's producing insulin. So I don't think the technology is all that difficult, but you need continuous funding. And Doug Melton at Harvard, his son, I think, had type 1 diabetes. And ever since that, for 20 years, he's been working only on this. Somebody like that who is driven always has a personal interest in it. Usually, if in type 1 diabetes, it is a person who is interested in that because of a family member. So he went on working. About 2 or 3 years ago, he got huge funding. He set up a company, Vertex. And then I was sure that there are some breakthroughs going to come. Now, the first human being has been cured of type 1 diabetes. Now, we'll have to see whether this cure lasts. Because in 2000, the year 2000, 12 type 1 diabetic children and adults were cured of type 1 diabetes by doing islet cell transplantation. One of my postgraduates and one of my PhD students, Priya Miranda, she was a zoologist and she did a zoology in Loyola, and then she joined me for PhD. I immediately halted her PhD and sent her to Canada, to Edmonton, and said there was no funding. I paid for her for 1 year and said, you go there and work with that person. And if it is good, then it's in Edmonton in Alberta in Canada. So I said, you go there and then you learn the entire technique, come back, and then we'll set it up here, because it was so promising. It's a New England Journal paper, 12 completely cured. So she learned the technique. While she was there, they did 45 islet cell transplant. But by the end of that year, it was beginning to get clear that those whom they had cured needed insulin again. And the islet cells had, the pancreatic islet cell transplant are all dried up. And so then by the time she came back, my enthusiasm had waned a little bit. And then I realized that I needed 8 crores to set up the islet cell lab, and I can do only 1 or 2 in a year. That means that 8 crores will go to treat one child, about which I was not sure about the future. At that time, Bill Clinton was the president in US, and he gave $1 million each to 8 labs in 10 labs in US and 2 in UK, and said replicate these findings. And those labs could not replicate Shapiro's findings. Of course, Priya went on to do her PhD on islet cells, and she did postmortem human pancreas of people who died in road accidents. And we did some very elegant work on islet cells, but never went on to actually do the transplant part of it and the cure part of it. I felt with that money, I could treat so many children with type 1 diabetes rather than take a gamble with 8 crores. And if it doesn't work, and I was right. I took the right decision in sending her. I also took the right decision in deciding not to proceed with that. Sometimes saying no is also important. And so that was the thing. But Doug Melton's, and the first man who has been cured is called Brian Shelton. And he has been in the news all over, and we'll hear more and more about it in the coming years. But then a lot of, and so therefore it's definitely light at the end of the tunnel. And I tweeted immediately today about that. But then there are so many questions. Is one infusion enough, or you'll need multiple? Number 2, how long will this last? And number 3, will it dry up like the islet cells? Number 4, suppose those islet cells, where are you going to put them? In the liver or somewhere else? Number 5, what happens if they start overproducing insulin? They develop uncontrollable hypoglycemia. How are you going to get rid of all of them? By the time some of the cells would have moved, and it's not like a thing which you can just go back. Pancreas you can remove, but this would have spread. So we don't know what will happen. Then a teratoma may form, and we might find an islet cell tumor occurring, which can produce hypoglycemia, and it can, all kinds of problems are there. So it's still very, very early to say, but that's how all science starts. And even Banting's first experiments were a total failure when they injected into the first child. And so I think beginning has been made, and I'm reasonably confident in 5 years' time, we should begin to see a cure for type 1 diabetes. That is my prediction. But type 2 will not go away, because type 2 is a very complex disease, but that's more manageable. If children with type 1 can be cured, then that's good. And actually, I've written my book, as I told you, my next book on relation to pre-diabetes, on relation to type 1 diabetes and the lives of everyone. That's getting ready. I'm going to send it off for publication to a good publisher. I'd written the epilogue, and there I'd said that stem cells are there, but we are far away. So I had to include that in the line saying, just today, as I'm writing this, the first case has been cured. And I hope by the time this book is gone, few more cases would have been cured. So that's how fast things change. When I wrote that 1 month ago, I could not imagine that they will announce the first cure. So that's how science progresses, and it needs people with commitment, of course, lots of money to do it. In India, to do this kind of thing, I'll need minimum about 10 to 20, if not 50 crores a year just for that work. And it has to be at least for 10 or 15 years, 500 to 1,000 crores I'll need. And whether we'll succeed in that, we don't know. At this stage, I'm very happy to treat free insulin to a lot of children and let somebody else discover it. We'll take it at that time. Why should we go and discover it, spending hundreds and hundreds of crores, which may go down the drain? Let them do it. We will take it after it comes. That's my approach. I've learned to be philosophical and spiritual after that. Talking about complications and Marvin Siperstein, that's a time when I grew up, 1970s. So I've been very carefully watching the work. And the slide that you showed of Marvin Siperstein showing retinopathy in pre-diabetes is very, very important, because when Marvin Siperstein was a very big name, and when he showed that in pre-diabetes itself, you will get complications, then the argument was, then why control diabetes at all? There were many people who did not believe in control of diabetes. I said, it's too late. The disease has already progressed. Whether you control or not, they're going to develop complications. A total waste of time controlling diabetes. All these diabetologists are a waste of time. And it's a cardiovascular disease. If you treat the cardiovascular disease and blood pressure, it's better. Diabetes control is useless. That is what it was. But there was one man, I'm trying to get his name, I was Googling and seeing I couldn't get it, because when I was a medical student, I was following that. So Siperstein, if you take out Siperstein's original work, I'm sure the other guy will be good. He went on saying that Siperstein is wrong. And this used to go on. Every ADA, there'll be a debate. Siperstein versus their other fellow. Was it Campbell?
I read about this, but
I forget that fellow's name, and I'm trying hard. It's not Nathan. It's not one of the famous. There's another guy, his contemporary, and they went on. Both are equally famous. And one guy will say, "Control diabetes, prevent complications." Other fellow will say, "No, Marvin Siperstein useless. No point in this." Marvin Siperstein like this David Nissen, always complete opposite. He will say, and then finally came the DCCT trial. And it was only after the DCCT trial was published in 1993 that it was proven beyond doubt that complications can be prevented. Before that, the Kroc study, Steno study, small ones could not prove it. Kumamoto study could not prove it. But once the DCCT study came, proven beyond doubt that control of diabetes prevents retinopathy, nephropathy, neuropathy. But it still didn't prevent cardiovascular disease. For that, we needed a Steno 2 study. But then they said this only in type 1 diabetes. Then we needed UKPDS for 1998. I'm sure in your next lecture, you're probably going to talk about that. Now, talking about, and of course, then it was shown that in type 2 also you can prevent the complications. Then by the Steno 2 study, it was showed we control sugar, blood pressure, and cholesterol. That's what I call as ABC mantra. A1C, blood pressure, and cholesterol. Then you can prevent the macrovascular or heart attacks as well. We talked about Lloyd Ilo. Lloyd Ilo has a legacy. His son, Paul Ilo, later joined Jocelyn Clinic. I think he's still there. I've met Paul Ilo. He collaborates with the Arvind Eye Hospital and he's come to India. And he was a young man. Now he's also grown quite old.
He's heading the unit now.
No, he's heading the unit now. Yeah. So he was also part of setting up this telemedicine, Jocelyn Vision Network and all that. And Beetham, who we mentioned, the Jocelyn Clinic eye unit is called Beetham Eye Unit. And the whole floor is kept for diabetic eye disease. And when we saw that, Rema and I went there and the whole floor was there. She said, I'll have a whole block for that. And that is how we have the Indira Eye Institute behind our hospital to which it's attached. And she named it after her mother, Indira Devi. And so Rema's dream was to have a full block only for diabetic retinopathy. I think that's the only one in the world where we have a full 3-4 story building only for diabetic retinopathy. And so that was inspired by the Beetham Eye Unit. And then the telemedicine, the ETDRS classification, by the way, we routinely use. And at all our epidemiological studies on retinopathy are using the ETDRS. If you have the photographs, the standard photographs, it's easy to then. Now we have software which will read it for you. Of course, it's a little complicated, but it can be done. And the last point is about telemedicine. I'm just happy to, it's a coincidence that this afternoon at 2 o'clock, I was, in fact, when Madam called me, I was reading that paper. We have written our paper and next week or so it will be submitted. 35 centers of ours in 30 centers, we used only the camera. In 30 of our branches across India, there is no ophthalmologist, but we have a camera. And that camera, Indian made, very inexpensive, low cost camera, can get pictures into our main center. And within half an hour of the picture being taken, whether the person is in Calcutta or Bhubaneswar, in one of our branches, it doesn't matter. A full-fledged report after the ophthalmologist has seen it is given back to the patient, and the diabetologist then gives the result to the patient with the result saying whether it's normal or it's mildly abnormal or whether it's proliferative and needs urgent laser or whatever is there, including if there are any other changes in the eye like cataract and all, they're also picked up. So we kind of spread this. I think the first diabetic unit of a chain. Jocelyn Network, of course, gets from other branches. They themselves don't have too many branches, but they get from across India. But this is all our own branches alone, 30 branches. And in 5 of our main branches where ophthalmologists and retinal surgeons are there, we did face-to-face with the direct ophthalmoscopy, indirect ophthalmoscopy, and the standard Zeiss camera. So we compared the two, and the use of without ophthalmologist, just a camera there and just a technician taking the picture. And this is the first report. We had 58,000 patients in 1 year whom we screened through. I think it's the largest in the world. So we have just written up the paper and very excited when I saw that, and just told Dr. Rajalakshmi, our present head, that we should put it into a good journal. So we are going to do that. So telemedicine works, and what I wanted to say was that it definitely works, and it doesn't need trained people. In some of the centers, dietitians take the pictures. So we make the patient sit there, and then if necessary, we dilate the eyes. We have non-mediatic also. Just take the picture and then zoom it into Chennai. In 25 to 30 minutes, they'll get the report, because there's one ophthalmologist on duty who's only reading all the other. And we have 6 or 7 trained retinal surgeons, and each one looks after 10, 20 branches. So they can get the images anytime. So these things are becoming very, very possible today. And I think in a similar way, you can also screen, as you said, for the feet and for other complications also, it can be screened. So today technology is taking us to, and this is actually, it can come on your cell phone as well. This picture can come on your cell phone, and it also has software to tell you whether it's normal, abnormal or not. Even in the absence of ophthalmologist, we have ophthalmologists who are using it, but you don't have an ophthalmologist, it can still tell you whether the images are good or not. So from the days of the people whom you showed, the pioneers, things have moved so much. They become smaller, more flexible, cheaper, more widely disseminated. And today with all the technology and internet and so on, sky is a limit. The only thing is we still don't have the cure. And today is a historic day because today is the first announcement of the cure of the first type 1 diabetic patient. So things are happening very fast, and I'm very happy that we are living in very exciting times. And it's very nice to go back on the history and look at all the pioneers who had to struggle those days. So I thought I'll just make those comments. Thank you.
Thank you so much.
Jairam, sir.
Listen to you.
Jairam.
Sir, just a basic doubt. Is there any link between the blood group and diabetic complication? Any particular blood group
It's been
prone for
studied.
diabetic complication?
Yeah, it's been studied, but I think it's too crude a method, because there are only 4 or 5 blood groups. That means everybody should fall into 4 classes. Diabetes is much more complex than that. The next refinement of that was to study the HLA patterns in type 1 diabetes, which is a much more sophisticated way of looking at genes in type 1. And of course, definitely there we know that the HLA-B, DR3, DR4, and so on are makes you more prone to type 1 diabetes, and the DR2 protects you against type 1 diabetes. They further defined it to DQ beta is the one which is making you more prone to, and there are also some which protect you from complications. We recently published our long-term paper on type 1 diabetes, where those who had more than 40, 50, 60, and even 70 years with type 1, we published it. What we found and what we reported at the end of the paper is very good, that they looked after their diabetes well. But it's not just because they kept their HbA1c below 7 all their life for 60, 70 years. For the first 10 or 15 years, they took one plain insulin. And I don't know how they even lived at that time. And then they went on for 15 years, they did that. I used to teach that if after 15 years you take 1 or 2 injections plain insulin, you'll definitely get diabetic kidney disease. I used to teach all my students. I'm wrong. There are people who don't develop. So there is a definite genetic factor. So now we've taken all their blood for genetic studies, and there is something, and it's not as simple as blood group and all that. But if you go deep into the genetics, there is a genetic factor which protects you from complications. And there's also some genetic factor that makes you more prone to complications. The man who had only 5 years duration, he's lost his vision, lost his kidney, lost everything. He's only 18 years old. And by the time everything gone, every organ gone, you know. So that is also there.
Thank you, Sairam.
Thank you.
Rangaraj?
Doctor, at what age is type 1 diabetes generally diagnosed now? Because I noticed that the complication rate is about 10%, even at the age of 10 years from the graph which Dr. Nallaperamal showed. So has the discovery of insulin made any difference? I mean, if the patients are diagnosed to be diabetic only after 10 years, some of them would have already gone into that stage, isn't it?
Madam, and type 1 diabetes is not possible, madam, because they will die. If then it's not type 1 diabetes. In type 2 diabetes, it's possible. So that is why I said, the age of that patient is only 18 years and still they develop. You may say, well, they'd have missed it for 20 years. Well, I was only 18 years old. He couldn't have missed it for 20 years. Or he couldn't have, he's already got 8 to 10 years. He couldn't have got it before he was born. So there is a definite genetic factor. Dr. Nallaperamal showed a beautiful graph, one of the most important of the Jocelyn's data of how it evolved. And if you see in the 1920s, before 1920s, 100% of the death was due to diabetic coma. Other things didn't develop. You needed 5-10 years to develop kidney disease and retinopathy or heart disease or any other, even tuberculosis and all that. They died before that. So you'll find at the top of the left-hand corner is a completely coma. And then you saw that graph coming down, the black thing, where coma came down so much and the other complications started coming, but they're living longer. So they developed retinopathy, nephropathy. There's no retinopathy and all at that time. They died before that. Within 1 year, the child is dead. How will you get retinopathy? So if somebody at diagnosis, this is a clue for you. If somebody at diagnosis of diabetes has retinopathy, and we find that in 5 to 6% of type 2s, if you take a picture on the day they are diagnosed, 6 to 7% can have retinopathy. That means they've already missed the bus for 5 years. This cannot happen in type 1. It straight away rules out type 1. So they'll be dead by then. So that means that diagnosis type 2, and such a child, I'll think of type 2 diabetes or MODY or something else. So children cannot live for 5 years without insulin. It's quite rapid in the progression.
At what age is type 1 diabetes generally diagnosed?
From the age of 1, it can be diagnosed, even actually from birth also it can be diagnosed. But from 0 to 6 months of age, it is usually not type 1 diabetes, it is neonatal diabetes. Having said that, about 2 or 3 years ago, about I think 5 years ago, in an international meeting, I had 2 children who were only 3 months and 4 months of age. So I presented that, I didn't present it, in a discussion with Dr. Andrew Hattersley. This is where, the white people will put us down completely. So I said, he made a statement that below 6 months, not a single type 1 diabetes is there in the world. I said, that's not true. I have seen, because my experience is much more than these guys. So I said, I have seen a couple of cases which are 3-4 months of age. He told me, you go and learn your diabetes again, he said. It's obvious you don't know diabetes. You better go and learn your diabetes again, he said. When he says like that in an international audience, what do? He's insulted you. Thank you, I said, and I went and sat down. Okay. This year, he has published type 1 diabetes below 6 months of age, a series he has published. Okay. So they'll put you down, totally misguide you, so that you don't work on it, and then they'll publish it immediately. This is science. This is how science progresses. So all the things that they say are not true. But after 6 months, neonatal diabetes becomes less common. Type 1 picks up. Between the ages of 1 and say 7 or 8 years, it's almost always type 1. Then other types of diabetes, MODY will start, type 2 will start. And after 10-15 years, type 1 will start coming down. Type 2, MODY, and all the other types will increase. But type 1 can come even at 70 years of age. With somebody who's 70 years can suddenly become severe type 1, become ketotic. So that is why the earlier it was called juvenile diabetes and maturity onset diabetes. That term was removed because you can get maturity onset diabetes in the young, that's called MODY. You can get juvenile onset diabetes in the elderly. So that is why they say, let's call it type 1 and type 2.
And what can obstetricians and pediatricians do to detect it earlier?
For type 1, you don't need to do anything, madam. It's so explosive. We don't go and screen for type 1 diabetes because the incidence is like 1 in 1 lakh or 2 lakh population. We'll have to screen 2 lakh children to pick up that one child, and that child would already be diagnosed. The only thing is, if they come to hospital, we should not miss. If they come with a fever, check the blood sugar. If they come with a headache, check the blood sugar. If they come with some undiagnosed symptoms, check the blood sugar. So just like you check the pulse, BP, respiratory rate, and temperature, this is the 5th vital sign. Just put a glucometer and see. If you find 500, it is diabetes already. You don't have 5 seconds, you'll know. Let it be normal for everyone. Doesn't matter. You'll pick up that one case if you pick up. Similarly, hypoglycemia also you'll pick up. That's the only thing we need to do. Any child coming to hospital, do the blood sugar. Testing, screening, going out into the community and screening is not recommended at all. It's not at all cost effective. Child will come with symptoms very fast within the first 2 or 3 months. Itself, they'll become symptomatic. And then educate everybody about the symptoms. If the child has thirst, loss of weight, vomiting sensation, nausea, think of diabetes, think of diabetes. Inform all the pediatricians, inform all the neonatologists, inform all the clinics, all the doctors. If that is done, then that is sufficient. You don't have to go and screen.
Thank you, Doctor.
Thank you. Dr. Anybody? Dr. Maragadamani?
I'm sorry, I'm answering all the questions.
I know.
Speaker should
You are there. You are
Rangaraj,
supposed to answer.
Rangaraj, I think he has already left.
There is one more question actually. And any ideal prophylaxis for prevention of diabetes complication? The chat box. Any ideal prophylaxis?
Then oral,
Yes, prophylaxis.
something about oral insulin also.
Oral
I think
insulin.
Sundaramurthy was
Oral
actually-
insulin has been tried a lot, and we were part of the discovery in Biocon, where a pill called a Strego pill, we tried the first round about 4 or 5 years ago. The second round, we failed only last year. And I was talking to Kiran Majumdar Shah even last week. She actually called me for on World Diabetes Day. And it's a failure. The failure is not in developing the oral pill, but in the dose which has to be used. The bioavailability is only about 1%, 2%. So you'll have to take 100 times the dose. If you need 20 units, you'll have to take 2,000 units. So then the cost will go up 100 times. Then it will become, 100 times the cost of insulin to take a pill. And even then a long-acting preparation we don't have. So only the short-acting. So it's not cost-effective. So both Novo and Biocon have kept it on hold. Now they're trying to see whether in some other way it can come. But the good news is that next week, oral semaglutide is going to be released. And oral semaglutide is the first peptide in a pill. It's the first, the protein thing which is coming in a pill. So if they can do it for semaglutide, insulin is not far away. So we might get an insulin pill soon.
Madam?
Prophylaxis prevention
Yeah.
to prevention of complications, A, B, C, D mantra. A is A1C, keep the A1C under control. B, blood pressure under control. C, cholesterol, LDL cholesterol under control. D is discipline, which include diet, exercise, self-monitoring, regular checkups. Everything comes under D. If you do these 4, we believe that 95, 98% of complications can be prevented. 1 or 2% are genetic. It's very difficult to prevent. I'll stop. Thank you.
Thank you, sir. Thank you very much. Madam?
Yeah, it was a very wonderful session, and as usual with Dr. Nalla Perumal, and we had a bonus session by Dr. Mohan sir, giving us all the inputs about the latest and what we can expect and what is going on in the diabetic arena. Thank you, Dr. Mohan, for enlightening us in this aspect, and also Dr. Nalla Perumal. We look forward to your future sessions also. Thank you once again.
There are 3 more to go on Nalla Perumal. 12,
Yes, sir.
12-part series, no?
3 more.
Yes. Yes, sir. Oral drugs and some advancements about monitoring technologies.
Next month, when
and
will
clinical
you,
trials.
next month,
Yes.
when will you be free? Please tell us. According to that, we can have the date also. On Sunday. Is it okay on Sunday for you?
Yeah, let me know some dates, madam, and then I'll
Okay.
confirm it like you.
Okay. I'll discuss with Dr. Nalaperumal and
Yeah,
then
yeah,
come back
please,
to this.
please.
Thank you. Thank you very much. Thank you, everybody, for your patient listening and for the wonderful session with both Dr. Nalaperumal and Professor Mohan. Thank you, madam, for being with us. Thanks all the participants. Thank you very much.
Thank you.
Great session today.
Hello, Shanta.